Hello friends, today's topic of discussion is acute mesenteric ischemia. Acute mesenteric ischemia is caused by sudden interruption of the blood supply to the intestine, leading to cellular damage, intestinal necrosis, and commonly patients death if untreated. Acute mesenteric ischemia may be occlusive or non-occlusive, with primary etiology further defined as mesenteric arterial embolism, mesenteric arterial thrombosis, or mesenteric venous thrombosis. Acute mesenteric arterial embolism. Half of the cases of acute mesenteric ischemia are due to acute superior mesenteric artery embolism. Mesenteric emboli can originate from the left atrium, left ventricle, or from the cardiac valves. Occasionally, emboli are generated from the atherosclerotic aorta. Emboli typically lodge at the point of normal anatomic artery narrowing. The superior mesenteric artery is particularly vulnerable because of its relatively large diameter and low takeoff angle from the aorta. The majority of emboli lost 3 to 10 centimeter distal to the origin of superior mesenteric artery, thus sparing most proximal jejunum and colon. More than 20% of superior mesenteric artery emboli are associated with concurrent emboli to another arterial bed, including spleen and kidney. Acute mesenteric arterial thrombosis. Thrombosis of superior mesenteric artery, approximately 25% of cases, is associated with the pre-existing chronic atherosclerotic disease leading to stenosis. Many of these patients have history of consistent with the chronic mesenteric ischemia, including postprandial pain, weight loss, or food fear. A detailed medical history is important when evaluating patients suspected to have acute mesenteric ischemia. Thrombosis usually occurs at the origin of visceral arteries. An underlying plaque in superior mesenteric artery usually progress eventually to critical stenosis, resulting in collateral bleeding. Accordingly, symptomatic SMA thrombosis most often accompanies celiac occlusion. SMA thrombosis may also occur due to vasculitis, mesenteric dissection, or mycotic aneurysm. Involvement of ileocholic artery will result in necrosis of proximal colon. Acute non-occlusive mesenteric ischemia. Non-occlusive mesenteric ischemia occurs in 20% of cases and is usually consequences of SMA vasoconstriction associated with the low splanchnic blood flow. The compromised SMA blood flow also affects proximal colon due to involvement of ileocholic artery. Patients with non-occlusive mesenteric ischemia typically suffer from severe coexisting illness, commonly cardiac failure, which may be precipitated by sepsis. Hypovolemia, the use of vasoconstrictive agent, may precipitate non-occlusive mesenteric ischemia. Mesenteric venous thrombosis, it accounts for less than 10% of cases of mesenteric infarction. Thrombosis is attributed to combination of virtuous trial, that is stagnant blood flow, hypercoagulability, and endothelial damage. In young patients, 36% of mesenteric venous thrombosis occurs without obvious cause. An inflammatory process around the superior mesenteric vein due to acute pancreatitis and inflammatory bowel disease may cause thrombosis. Surgical trauma such as splenectomy, bariatric surgery may also provoke superior mesenteric vein thrombosis. Hypercoagulability may be due to inherited disease such as factor V laden prothrombin mutation, protein S deficiency, protein C deficiency, antithrombin deficiency, and antiphospholipid syndrome. Additionally, recent work suggests the fibrinolysis shutdown is also risk factor for hypercoagulability. Thrombophilia may also be acquired due to malignancies, hematologic disorders, and oral contraceptives. Now, the incidence mesenteric arterial embolism decreased to 25% of cases. Mesenteric arterial thrombosis was the second most common cause of mesenteric ischemia, which historically accounts for 20 to 35% and recently increased to 40%. Naomi accounts for 25% of cases. Now, the risk factors are heart failure, renal failure, cardiac surgery using cardiopulmonary bypass, the use of catecholamine, patient age 75 years or older, Acute mesenteric ischemia is more prevalent cause of acute abdomen than appendicitis. The incidence of acute mesenteric ischemia in 80-year-old is roughly tenfold than that of 60-year-old patient. Now, symptoms: severe abdominal pain out of proportion to physical examination finding should be assumed to be acute mesenteric ischemia until disproved. The clinical scenario of the patient complaining of excruciating abdominal pain with unrevealing abdominal examination is classic for early acute mesenteric ischemia. The reason for the pain being disproportionate to the clinical finding is that ischemia starts from mucosa towards cirrhosis. This is why initially there is severe pain without clinical finding. Regarding physical examination, if physical examination demonstrates signs of peritonitis, there is likely irreversible intestinal ischemia with bowel necrosis. In study on acute mesenteric ischemia, 95% of patients presented with the abdominal pain, 44% with nausea, 35% with vomiting, 35% with diarrhea, and 16% with the blood per rectum. Approximately one-third of the patients present with the triad of abdominal pain, fever, and hemoccult positive stool. Other patients, particularly those with delayed diagnosis, may present in extremis with septic shock. Clinical signs of peritonitis may be subtle. Accordingly, one must have high index of suspicion because such a findings are predictive of intestinal infection. Classic presentation of acute mesenteric ischemia, that is severe, poorly localized abdominal pain that is out of proportion to the physical examination, is becoming less common, while acute and chronic presentations of mesenteric ischemia are more typical, probably underdiagnosed. Patients presenting with symptomatic chronic mesenteric ischemia, they are at high risk of developing in-hospital acute mesenteric ischemia. Severe COVID-19 infection and acute mesenteric ischemia have poor prognosis, delay in diagnosis, and intervention. Acute mesenteric ischemia should be suspected in patients with COVID-19 who presents with nausea, vomiting, diarrhea, abdominal pain, and abdominal distension because of hypercoagulability and hypoperfusion. Blood test will not aid in diagnosis of acute mesenteric ischemia, though essential in patient management. CT angio is the diagnostic modality of acute mesenteric ischemia, along with clinical correlation. Careful medical history is important because distinct clinical scenarios are associated with pathophysiological form of acute mesenteric ischemia. Patients with the mesenteric arterial thrombosis often have history of chronic postprandial abdominal pain, progressive weight loss, previous revascularization procedures for mesenteric arterial occlusion. Patients with NOMI have a pain that is generally more diffuse and episodic, associated with poor cardiac performance. These patients are more likely to have suffered from cardiac failure and recent surgery. Several studies also reported hemodialysis as a risk factor of the NOMI. Furthermore, NOMI presents a cause of secondary worsening in septic shock, particularly in septic patients treated with high-dose vasoactive drugs. Patients with mesenteric vascular thrombosis present with the mixture of nausea, vomiting, diarrhea, and abdominal cramp. GI bleeding occurs in 10%. Nearly 50% of patients present with the embolic AMI have atrial fibrillation, and approximately one-third of the patients have prior history of arterial embolus with pre-existing peripheral vascular disease. Now, risk factor for specific type of acute mesenteric ischemia. Acute mesenteric arterial embolism, the risk factors are atrial fibrillation, recent MI, cardiac thrombi, mitral valve disease, left ventricular aneurysm, endocarditis, previous embolic disease. Clinical onset, sudden strong abdominal pain and vomiting. Vascular involvement, main artery or branches of the superior mesenteric artery. Acute mesenteric thrombosis risk factors are diffuse atherosclerotic disease, postprandial pain, and weight loss. Clinical onset, progressive sudden abdominal pain, vomiting, diarrhea, malaria. Vascular involvement, celiac trunk, superior mesenteric artery, inferior mesenteric artery, which. Then the next terminology is the non-occlusive mesenteric ischemia. The risk factors are cardiac disease, low flow state, multi-organ dysfunction, vasopressor, abdominal compartment syndrome. Clinical onsets are progressive pain, mild. Vascular involvement, superior mesenteric vein, progress to the portal. Then the next terminology is mesenteric venous thrombosis. The risk factors are portal hypertension, history of venous thromboembolism, oral contraceptives, estrogen use, thrombophilia, pancreatitis. Clinical onset, non-specific GI symptoms, abdominal distension, worsening of general condition. Vascular involvement, stenosis of superior mesenteric artery. Plain X-ray is not recommended in evaluating patient for intestinal ischemia. Although lab results are not definitive, they may help in corroborate clinical suspicion. More than 90% of patients will have abnormally elevated leukocyte count. The second most common encountered abnormal finding is metabolic acidosis with elevated lactate, which occurs in 88%. The presence of lactic acidosis in combination with abdominal pain, when patient may not otherwise appear clinically ill, should lead to consideration of early CT. D-dimer has been reported to be independent risk factor for intestinal ischemia, reflecting ongoing clot formation and endogenous degradation via fibrosis. D-dimer more than 0.9 mg had specificity, sensitivity, and accuracy of 82%, 60%, and 79% respectively. Thus, D-dimer may be useful in early assessment. Elevated amylase has been reported in roughly half of the patients with acute mesenteric ischemia. Other biomarkers reported to be used in diagnosis of AMI include intestinal fatty acid binding protein, serum alpha glutathione, S-transferase, cobalt albumin binding acid. The three most promising circulatory biomarkers for AMI: citrulline, fatty acid binding protein, D-lactate, were neither sensitive nor specific enough for differential diagnosis of acute mesenteric ischemia. Now, rule of radio imaging. Computed tomography angiography should be performed without delay in any patient with suspicion for AIM. Delay in the diagnosis is the dominant factor that accounts for high mortality rate of 30% to 70%, despite increased knowledge of this entity. Every 6 hours of delay in diagnosis doubles the mortality. A multi-detector CTA has replaced the formal angiography as diagnostic study of choice. In the presence of advanced acute mesenteric ischemia, CT angio finding reflects the irreversible ischemia, intestinal dilatation in thickness, reduction or absent visceral enhancement, pneumatosis intestinalis, portal venous gas, especially the combination of all and free intraperitoneal air. Comprehensive biphasic CTA includes the following important steps: the pre-contrast scan to detect vascular calcification, hyperattenuating intravascular thrombus, and intramural hemorrhage. Arterial and venous phase to demonstrate thrombus in mesenteric arteries and veins, abnormal enhancement of bowel volume, and presence of embolism and infarction of other organs. Multiplanar reconstruction to assess the origin of mesenteric arteries. The oral contrast is not indicated and even harmful. CT angio should be performed despite the presence of acute kidney injury, as consequences of delayed or misdiagnosis as far more detrimental for patient than exposure to iodinated contrast. In non-occlusive mesenteric ischemia, CT angio may demonstrate bowel ischemia and free flow in face of patent mesenteric vessel. Mesenteric venous thrombosis, the most common positive radiological finding on venous phase, CT angio's thrombus in superior mesenteric vein described as target sign. Associated finding that suggest the mesenteric vascular thrombosis, bowel wall thickening, pneumatosis, splenomegaly, and ascites. Portal and mesenteric venous gas strongly suggest the presence of bowel infection. Duplex ultrasonography has limited role in this entirety, but may be helpful if obtained early in the chronic cases. It could be useful for to monitor bowels, peristalsis, and amount of free peritoneal fluid, especially in MRI is established technique in the evaluation of mesenteric arterial and venous vasculature in patients with suspected AIM. It has been well accepted for chronic mesenteric ischemia cases and functional assessment of bowel insufficiency as a result of superior mesenteric artery pathology. Now, non-occlusive mesenteric ischemia. Non-occlusive mesenteric ischemia should be suspected in critically ill patient with abdominal pain or distension requiring vasopressor support and evidence of multi-organ dysfunction. Unexplained abdominal dysfunction or gastrointestinal bleeding may be the only sign of intestinal ischemia in adult and may be detectable in sedated patient in ICU, approximately 25% of cases. Patients surviving cardiopulmonary resuscitation who develop bacteremia and diarrhea should be suspected of having non-occlusive mesenteric ischemia, regardless of presence or absence of abdominal pain. Right-sided abdominal pain associated with passage of maroon or bright red blood in stool is highly suggestive of non-occlusive mesenteric ischemia. Use of vasopressors such as norepinephrine and epinephrine might result in impaired mucosal perfusion. Other pharmacological agents such as vasopressin and digoxin, as well as acute profound hypovolemia, could also worsen ischemia. Lastly, the role of enteral nutrition in critically ill patients on development of intestinal ischemia is controversial. In general, enteral parenteral nutrition is complementary to meet patients' daily caloric requirements. In the recent randomized controlled trial, Nutria 2, enteral nutrition was compared to parenteral nutrition, and mortality did not differ between two groups. But significantly higher rate of bowel ischemia was reported in the enteral group. Initial management. When the diagnosis of AMI is made, fluid resuscitation should commence immediately to enhance visceral perfusion. Electrolyte abnormalities should be corrected and nasogastric decompression initiated. Fluid resuscitation with the crystalloid and blood product is essential for management of patients with suspected AMI. Preoperative resuscitation is important to prevent cardiovascular collapse on induction of anesthesia. To guide effective resuscitation, early hemodynamic monitoring should be implemented. Assessment of electrolyte level, acid-base status should be performed. This is especially true in patients with acute mesenteric ischemia, where severe metabolic acidosis and hyperkalemia may result from underlying bowel infarction and preperfusion. Vasopressor should be used with caution. Dobutamine, low-dose dopamine, meldonium to improve cardiac function have been shown to have less impact on mesenteric blood flow. The fluid volume requirement in this patient may be high due to extensive capillary leakage, but the infusion of large volume of crystalloid should be utilized carefully to optimize bowel perfusion. The goal of therapy should address physiological level of oxygen delivery with continued monitoring of lactate level as indication of perfusion improvement. Regarding antibiotics, broad spectrum antibiotics should be immediately administered. The high risk of infection among patients with acute mesenteric ischemia outweigh the risk of acquired antibiotic resistance, and therefore broad spectrum antibiotics should be administered early in the course of treatment. Intestinal ischemia leads to early loss of mucosal barrier, which facilitates bacterial translocation and the risk of septic complications. Antibiotic therapy should be administered for at least 4 days in immunocompetent stable patient, with consideration given to longer duration of therapy for signs of ongoing infection. As soon as possible, antibiotic regimen should be tailored according to the microbial isolation. Laparoscopy and laparotomy. Prompt laparoscopy and laparotomy should be done for patients with overt peritonitis. The goal of surgical intervention for acute mesenteric ischemia include re-establishment of blood supply to the ischemic body, resection of all non-viable region, and preservation of all viable body. Intestinal viability is the most important factor influencing outcome in patient with acute mesenteric ischemia. Non-viable intestine, if unrecognized, result in multisystem organ dysfunction and ultimately death. Prompt laparotomy allows for direct assessment of bowel viability. Emergency laparotomy. After initial resuscitation, midline laparotomy should be performed, followed by assessment of all areas of intestine with decision of resection of frankly necrotic areas. Re-establishment of blood supply to ischemic body. Different techniques of the blood flow restoration are used depending on the AMI pathophysiology. Embolectomy and angioplasty are well-established definitive treatment for SMA involvement. On other hand, thrombosis of SMA at the origin of aorta will require bypass procedure. Bypass may be performed in either antegrade fashion from suprailiac aorta or retrograde fashion from infrarenal aorta or common iliac arteries. Single vessel revascularization is usually sufficient in acute setting. However, it increases magnitude of the procedure and may require prosthetics in presence of contaminated fluid. Nowadays, endovascular procedures reduces requirement for surgical bypass. Thus, multidisciplinary collaborative approach, including specialists from multiple disciplines, is integral for good clinical outcome. Temporary SMA shunting may spare considerable burden. For patients in the extremes or where necessarily technical skill set is not available, temporary SMA shunting should be considered. Neither MOMI nor NBT requires vascular repair. High-dose anticoagulation should be initiated on all patients prior to surgical procedure. Unfractionated heparin is effective and easy to manage, especially in patients with acute kidney injury. Regarding laparoscopy, diagnostic laparoscopy is feasible as a bedside procedure in intensive care unit, with advantage of avoiding time delay for awaiting operating room availability and preventing adverse event during critically ill patient transfer. However, the routine use of diagnostic laparoscopy has not been generally adopted. When a second look surgery is indicated, second look laparoscopy may be useful alternative to conventional surgery because it prevents critically ill patient from trauma and the risk of re-laparotomy and can be performed as ICU bedside procedures. The European Association for Endoscopic Surgery consensus for laparoscopic approach to acute abdomen states that there is no published data demonstrating advantages in diagnosis and treatment of acute bowel ischemia by laparoscopy. However, laparoscopy can be useful in confirming diagnosis in doubtful cases. Evaluate the extension of ischemic small bowel segment and offer treatment option in cases of segmental necrosis. In addition, post-cardiac surgery patients admitted to ICU have relatively high rate of where CT scan can be equivocal. In this case, the bedside diagnostic laparoscopy may be safe and effective procedure. Now, these are the various endovascular procedures in the occlusion of superior mesenteric artery. So, first one is aspiration embolectomy. Advantages are lower mortality, patient without peritonitis, and repeat procedure. Second one is SMA thrombolysis. The advantages and challenges are it has a bleeding complication, laparotomy required in 38%, patient without peritonitis, contraindicated in recent surgery, trauma, cerebrovascular, GI bleeding, and uncontrolled hypertension. Antegrade stenting, there is always risk of dissection and unfavorable artery engorgement. Retrograde stenting, laparotomy necessary, avoiding bypass when necrotic bowel presence. Success rate is 95%. Endovascular intervention associated with lower mortality compared to the open surgery. Hybrid approach is endovascular intervention and surgery. Retrograde open mesenteric stenting is emerging hybrid technique utilized in case of acute mesenteric ischemia. This procedure includes laparotomy and retrograde endovascular revascularization of superior mesenteric artery. One of the advantages of this method over vascular bypass is significantly shorter operative time. One of the major concerns after stenting is patency. However, patency rates similar to the bypass were reported. Theoretically, if technical capabilities and infrastructure for hybrid procedure are available, then retrograde mesenteric stenting is a good treatment option for patients who require laparoscopy. It is possible that ROMS may avoid the need of loop surgeries. The role of damage control surgery. Damage control surgery with temporary abdominal closure is important agent for patients who require intestinal resection, allowing reassessment of bowel viability and in situations of severe abdominal sepsis. The damage control strategy is acceptable technique in trauma care for past 30 years. It is important option for inpatient with aim. Damage control is the surgical modality of choice, particularly in patients with acute mesenteric ischemia for pathological and technical reasons. The decision to utilize damage control surgery should be made early based upon the response to resuscitation. Advanced age is not contraindication to damage control surgery, as good outcomes have been observed in the elderly. Planned second loop techniques are required after restoration of superior mesenteric artery flow without resection of ischemic bowel following resuscitation in ICU. If there is uncertainty regarding bowel viability, stapled off bowel ends should be left in discontinuity and re-inspected after a period of continued ICU resuscitation to restore physiological balance. Often bowel, which is borderline ischemic at initial re-exploration, will improve after re-exploration of blood supply and pathological stabilization. Re-exploration should be achieved in 24 to 48 hours. Mesenteric venous thrombosis can often be successfully treated with continuous infusion of unfractionated heparin. The first-line treatment for mesenteric venous thrombosis is anticoagulation. Systemic thrombolytic therapy is rarely indicated. When clinical science demands the operative intervention, one should resect only obviously necrotic bowel utilizing damage control technique, since anticoagulation therapy may improve clinical picture over ensuring 24 to 48 hours. Early use of heparin has been associated with improved survival. Patients with peritonitis require emergency surgery. Intraoperative management is dictated by surgical findings ranging from segmental infarction of small bowel to necrosis of entire bowel with or without perforation. The aim of resection is to conserve as much bowel as possible. Second look laparotomy 24 to 48 hours later may avoid resection of potentially viable bowel. Second look procedure is mandatory in patients who have extensive bowel injury. Now the treatment of NOMI. The focus is to correct underlying cause and improve mesenteric perfusion. Infected bowel should be resected from. The central principle of NOMI management is the treatment of underlying precipitating cause. Fluid resuscitation, optimization of cardiac output, and elimination of vasopressor remains important primary measures. Additional treatment may include systemic anticoagulation, use of catheter-directed infusion of vasodilatory and antispasmodic agent, most commonly papaverine hydrochloride. The decision to intervene surgically is based on presence of peritonitis, perforation, and overall worsening of the patient's condition. If patient present with the peritoneal sign, the exploratory laparotomy is required for resection of frankly necrotic bone. Unfortunately, these patients are often in critical condition. Mortality remains very high. Damage control surgery is important action given critical state of this patient. Direct vasodilator infusion of papaver to SM should reduce the mortality associated with it. Another study demonstrated that early treatment with continuous IV prostaglandin reduces the mortality in patients with now. Vasodilator therapy is associated with the lower in-hospital mortality. Post-operative intensive care of acute mesenteric ischemia patient is directed towards the improved intestinal perfusion and prevention of multiple organ failure. Treatment of acute mesenteric ischemia is optimal in dedicated center using focused care bundle and multidisciplinary team. Patient with short bowel syndrome following extensive bowel resection should have restoration of digestive continuity in association with hormonal therapy to optimize the absorptive function and achieve nutritional properties. In case of massive gut necrosis, careful assessment of the patient, underlying comorbidities, and advanced directives is advisable to find optimal therapeutic strategy, which include palliation. Patient undergoing revascularization should have surveillance imaging and long-term anticoagulation. So this is the schematic representation of acute mesenteric ischemia. So the common presentation is severe abdominal pain, which is if you are and if you are suspecting acute mesenteric ischemia, then we should assess for the risk factor. Order some specific lab investigations like D-dimer, lactic acid, and WBC. Then we start with fluid resuscitation, antibiotic, nasogastric suction, electrolyte abnormality correction. Then go for CT entry. In acute mesenteric ischemia, findings are superior mesenteric emboli, superior mesenteric artery thrombosis, non-occlusive mesenteric ischemia, and superior mesenteric vein thrombosis. Then initiate anticoagulation with the heparin. Now divide the patient into two categories, hemodynamically abnormal with peritonitis. Then they start with damage control surgery, possible revascularization, planned re-laparotomy, and anticoagulation. And if the patient is hemodynamically normal and no peritonitis, then transfer to specialized center, revascularization with the anticoagulation and laparoscopy. If there is peritonitis with bowel ischemia, then go for laparoscopy. Thank you.